Welcome back to the Deep Dive. Today we're talking about something absolutely fundamental. It's the system that, it literally connects every single cell in your body to the outside world.
It's the great delivery service.
It is. It's the fluid that keeps you alive, but it's also, the fluid that can cause so many problems if it stops moving or if it starts moving into places it shouldn't be. We were talking about blood.
It's often called the liquid organ, which I think is a fantastic description.
I love that.
Yeah.
Liquid organ. Because you think of organs as these, solid things, a liver, a heart. But blood is a tissue.
It is absolutely a tissue. It has everything a tissue needs. It's got cells, it's got a matrix, the plasma, and it performs, arguably one of the most dynamic functions in the entire body.
And for this deep dive, we are pulling from the absolute titans of the field. We're synthesizing the chapters on red blood cells and bleeding disorders from Robbins and Cochrane Pathologic Basis of Disease and Underwood's Pathology.
The two core texts. You can't get through medical school without them.
No, you can't. I think my copy of Robbins permanently indented my bookshelf.
And just to be clear for everyone listening, our goal here is not to just, read the textbook out loud.
Right, that would be pointless.
The mission is to build a conceptual map, a scaffold. We want you to understand the mechanisms. Why do these diseases present the way they do? Why does one faulty protein lead to a patient's spleen eating all their red cells? That's the goal.
It's about moving from just memorizing lists of symptoms to understanding the why. And as I was reading, this central tension just jumped off the page. Blood has two jobs that seem, completely at odds with each other.
They are fundamentally in opposition. Think about it. Job number one is flow. It has to be a liquid. It has to move fast, get everywhere, and squeeze through capillaries that are narrower than the red cells themselves.
Okay.
That's all about delivery.
Okay, that's delivery. So what's job two?
Containment. Job two is that if there is any breach in the system, a cut, a tear, any kind of injury, it has to instantly transform from that liquid into a solid. It has to clot.
So it's a constant balancing act.
Yeah. A high wire act, absolutely, between being a free-flowing liquid and a solid plug. And pretty much all of hematopathology is what happens when that balance tips too far one way or the other.
So if the delivery system fails, you get anemia. Your tissues starve for oxygen.
Hypoxia.
And if the containment system fails, you either can't stop a leak, that's hemorrhage, or you plug things up when you shouldn't, and that's thrombosis.
That is our roadmap for today. Delivery failure versus containment failure.
Okay, so before we jump into the deep end, let's lay out the key takeaways. If you remember nothing else from this discussion, what are the four big ideas?
Okay, number one. Anemia is not just a low number on a lab report. It's a functional failure of oxygen delivery. It's about tissue hypoxia.
Got it. Function, not just numbers. What's two?
Second, the reticulocyte count is the single most important branch point when you're diagnosing anemia. It tells you immediately, is the factory broken or are the products being destroyed after they leave?
Factory versus destruction.
Okay. 3. Hemolysis, the destruction of red cells, is very often a battle between the cell's own flexibility and the spleen's ruthless filtration system.
The spleen as the villain. I like it. And number 4.
And finally, number 4. Haemostasis, or clotting, is all about balance. The pathology comes from a loss of control. Too little clotting gives you bleeding. Too much gives you thrombosis. And paradoxically, both at the same time gives you DIC.
A perfect summary. Okay, let's start with the delivery system. Let's talk about anemia. Now, I think most people have a pretty casual understanding of this. Oh, you're tired, you must be anemic. But the definition from Robbins is much more precise.
It is. Robbins defines it very structurally as a reduction of the total circulating red cell mass below normal limits, which is true, but...
But you prefer the Underwood's approach here.
I do, because Underwood's focuses on the consequence, the physiology. The real problem isn't the number of cells, it's the reduced oxygen carrying capacity. That's what makes the patient sick.
And that leads directly to tissue hypoxia.
Exactly, and this is a great first example of how mechanism explains the symptoms. Why does a patient with severe anemia feel exhausted? Why are they short of breath or dyspneic?
That's not a lung problem.
It's not a lung problem. Their lungs are working fine. The issue is that the blood can't pick up enough oxygen to deliver to the muscles, to the brain. The mitochondria in their cells are, for all intents and purposes, suffocating. They can't generate ATP.
And you mentioned something earlier that Underwood's points out that I found really striking. In severe chronic cases, this cellular suffocation can actually change the structure of organs.
It can, yeah. It's a process called fatty change, or steatosis. If an organ like the liver, or more critically the heart muscle, the myocardium, is starved of oxygen for a long time, the cells can't metabolize fats properly.
So fat just builds up inside the muscle cells.
It literally does. You get these tiny lipid vacuoles inside the myocardial cells. The heart is physically changing its architecture because it is desperate for oxygen. It's a sign of profound metabolic stress.
That's a powerful image, the heart literally gasping for air. Okay, so when a clinician is faced with an anemic patient, you have to figure out the why. And the textbooks give us two main ways to classify anemia. One is based on how the cells look, and the other is based on the underlying cause.
Right. Morphology and mechanism. What it looks like and why it happened.
Let's start with morphology, the look. This is where we get all those cytic and chromic terms. Microcytic, macrocytic, hypochromic.
It sounds like a lot of jargon, but it's incredibly useful. Cytic just refers to cell size. So microcytic means small red cells. Macrocytic, large red cells. Normocytic, normal sized.
And chromic refers to the color.
It refers to the color, which is really a proxy for how much hemoglobin is in each cell. Hypochromic means less color, so the cells look pale. Normochromic means they have a normal amount.
And Robbins gives this fantastic rule of thumb that helps you cut right to the chase. If the cells are small or microcytic.
It almost always means there's a problem with making hemoglobin.
Okay, unpack that for us. Why does a defect in hemoglobin production make the cells smaller?
It's a great question. Imagine the developing red blood cell is a factory. It has a set of instructions. One instruction is to divide a certain number of times. Another is to fill itself up with hemoglobin. The signal to stop dividing is basically when the cell reaches a certain concentration of hemoglobin. So if you can't make hemoglobin properly, maybe you're missing the iron for the heme group, the cell never reaches that critical concentration. So it divides one more time, try and concentrate what little hemoglobin it has.
It makes a smaller container for the limited amount of product.
That's a perfect analogy. It makes a smaller bag for the few groceries it could buy. The result is a microcytic, often hypochromic cell.
Okay, small cell means a problem with the contents. What about the other side of the coin? The big cells, macrocytic anemia.
That's a totally different problem. That's usually an issue with the process of division itself. It's a problem with DNA synthesis.
The cell can't replicate its own blueprints properly.
Exactly. The cell gets the signal to grow and prepare for division. So the cytoplasm gets bigger, it makes all its proteins, but the nucleus gets stuck. It can't properly duplicate its DNA to split into two daughter cells, so it just keeps growing.
Resulting in this giant, often fragile and dysfunctional cell.
A macrocyte. So you can see the power of just looking at the size. Small cell, think hemoglobin synthesis. Large cell, think maturation or DNA synthesis defect.
That's the morphology, the look.
Yeah.
But the real investigation starts with the cause, the mechanistic classification. This feels like the core of the diagnostic process.
This is where you become a detective. And it's actually beautifully simple. There are only 3 fundamental ways you can become anemic.
Just 3.
Just 3. 1, you're losing blood from the system faster than you can make it. That's blood loss or hemorrhage.
Okay.
2, the factory's broken. The bone marrow isn't producing enough red cells. That's a production deficit.
And 3.
3, the factory is working fine, but the red cells are being destroyed prematurely out in the circulation. That's increased destruction or hemolysis.
So, loss, production failure, or destruction. Simple enough. But here's the critical question. How do you tell the difference between a production failure and destruction? A low red cell count is a low red cell count.
This is where we come to our second key takeaway. You have to check the factory's production log. You have to look at the reticulocyte count.
The reticulocytes. The teenage red blood cells.
Exactly. A reticulocyte is a red blood cell that was just released from the bone marrow maybe a day or so ago. It's not quite mature. It still has a little bit of residual RNA inside it, a reticulum, which you can see with a special stain.
And why is that count the crucial branch point?
Because it tells you how the bone marrow is responding to the anemia. Think about it. If you're anemic, your tissues are hypoxic. Your kidneys sense that hypoxia, and they release a hormone called erythropoietin, or EPO.
Which is basically a screaming emergency call to the bone marrow.
It's a 5-alarm fire bell. It's screaming, "We need more oxygen carriers now!" A healthy bone marrow should respond by cranking up production and pushing out these young reticulocytes into the circulation to help.
So, if I'm anemic, but my reticulocyte count is high,
it means the factory is working. In fact, it's working overtime. The marrow has heard the alarm and is doing its job. Therefore, the problem can't be production. The problem must be that the cells are either being lost through bleeding or destroyed by hemolysis somewhere else.
Right. The production line is fine. The problem is with shipping or the product getting smacked at arrival.
Precisely. But if you are anemic and your reticulocyte count is low, or even inappropriately normal,
That's bad news.
that's very bad news. It means the alarm bell is ringing, but the factory is silent. No one is answering the call. That points directly to a primary failure of production in the bone marrow.
Okay, that is an incredibly clear and powerful distinction. Let's follow that path first, the silent factory. This brings us to the disorders of production, and we have to start with the global heavyweight champion, iron deficiency anemia.
The single most common nutritional disorder in the entire world. It affects billions of people.
And we've already established the basic mechanism. No iron means no heme means no hemoglobin, and that leads to these small, pale, microcytic, hyperchromic cells.
That's the end result. But Robbins dives into the fascinating regulatory mechanism behind it, which all centers on one key protein, hepcidin.
Hepcidin. It seems to be the master switch for iron metabolism.
It really is. You have to understand that iron is a double-edged sword. It's absolutely essential for life, for carrying oxygen. But free iron is also incredibly toxic. It generates free radicals, so the body controls it with an iron fist, so to speak.
And hepcidin is that fist.
Hepcidin is that fist. It's a hormone made by the liver, and when hepcidin levels go up, it does two main things. First, it blocks the absorption of iron from your diet in the gut, and second, it tells macrophages, which are the body's main iron storage cells, to lock their doors. They hold on to their iron and don't release it into the circulation.
So high hepcidin means low available iron in the blood. Why would the body ever want to do that?
Well, the main evolutionary driver seems to be infection. Most bacteria need iron to replicate. So when your body senses inflammation, which it often interprets as infection, it cranks up hepcidin production to hide the iron away from the invading microbes.
It's trying to starve the bacteria.
Exactly. It's a defensive strategy. But this leads directly to a really important clinical concept.
The anemia of chronic disease.
Precisely. This is a classic question. You have a patient with a chronic inflammatory condition like rheumatoid arthritis or a chronic infection like tuberculosis. They are anemic. Their red cells are often microcytic. It looks like iron deficiency.
But it's not.
It's not a true deficiency. If you were to measure their total body iron stores, they would be normal or even high. The problem is one of access. The chronic inflammation through cytokines like IL-6 keeps hepcidin levels sky high. All the iron is locked away inside macrophages.
So the bone marrow is starving for iron, even though the body's cupboards are full.
It's a functional iron deficiency. The key to the cupboard is missing. And that's why giving these patients iron supplements often doesn't work very well. The hepcidin just prevents it from being used.
That's a crucial distinction. Now let's get back to true iron deficiency. Robbins lays down a clinical rule. That is, well, it's quite stark. It says for an adult man or a postmenopausal woman, iron deficiency means you have gastrointestinal bleeding until proven otherwise.
This is one of those clinical pearls that you absolutely cannot forget because the implications are enormous.
Why that specific demographic?
Think about the normal reasons for losing iron. A premenopausal woman loses blood and therefore iron every month through menstruation. During pregnancy, the fetus requires a huge amount of iron. So iron deficiency in that group is common and often physiological. But a 65-year-old man, he shouldn't be losing blood.
So if he is iron deficient, you have to assume there's a leak somewhere.
You must assume there is a chronic, slow bleed. And the most common and most dangerous place for that leak is the GI tract. It could be an ulcer, but you have to rule out a malignancy, a colon cancer, for example.
So just giving that patient iron pills and telling them to eat more steak is malpractice.
It's a huge miss. You could be ignoring a treatable cancer while it progresses. You have to find the source of the bleeding. That means an endoscopy, a colonoscopy. You have to look.
It really highlights how a simple lab test can point to something so serious. Now, what about the physical signs? Underwood's lists some really unique and, frankly, bizarre symptoms. Let's start with koilonychia.
Spoon nails. Yeah, this is a classic sign. The nail bed becomes thin and concave. It literally dips in the middle like a spoon. It's thought to be due to dysfunction of iron-dependent enzymes in the nail matrix.
And then there's pica.
Pica is the compulsive eating of non-nutritive substances. With iron deficiency, the classic one is geophagia, the craving for dirt or clay.
And pagophagia.
That's the specific, intense craving to chew ice. We don't fully understand the mechanism, but it's a very specific symptom. If a patient tells you they can't stop crunching ice all day, you need to check their iron stores.
Fascinating. Okay, let's shift gears from small cells to big cells. The factory is still failing, but in a different way. Megaloblastic anemia.
The assembly line jam. We've moved from a raw material shortage iron to a problem with the manufacturing process itself, specifically a failure of DNA synthesis.
And the usual culprits are deficiencies in either vitamin B12 or folate.
Right. Both of them are essential cofactors for the synthesis of thymidine, which is one of the 4 bases of DNA. Without them, you can't build new DNA strands.
Yeah, we touched on this before. The cell gets bigger and bigger because it can't divide.
That's the nuclear cytoplasmic asynchrony. The cytoplasm grows, it's ready to go, but the nucleus is lagging behind, unable to replicate. The result is these giant abnormal precursor cells in the marrow called megaloblasts. And they're not just big, they're also fragile and dysfunctional. Many of them die before they even leave the marrow.
A process called ineffective erythropoiesis.
Exactly. The factory is busy, but the products are defective and get destroyed on the assembly line.
Now, Robbins issues a very stern warning here. He calls it a potential tragic trap when it comes to treatment.
This is another one of those critical, can't-miss clinical points.
Yeah.
B12 and folate deficiency look identical on a blood smear. You see big red cells, you see hypersegmented neutrophils. You can't tell them apart just by looking.
So you have to measure the levels of both vitamins.
You must, because here is the trap. If you have a patient with B12 deficiency and you mistakenly treat them with only folate,
The anemia gets better, right?
the anemia will partially correct, the blood count will improve. Folate can kind of bypass one of the metabolic blocks and allow for some red cell production. So you, the doctor, might think you've fixed the problem.
But you haven't.
You have made it much, much worse. Because vitamin B12 has a completely separate vital role. It's required to maintain the myelin sheath that insulates your nerves, particularly in the spinal cord. Folate does nothing for that.
So while the blood count is improving,
The patient's nervous system is degenerating. They are developing what's called subacute combined degeneration of the spinal cord. They lose their sense of vibration and position, they become weak, and eventually it can lead to irreversible paralysis.
that is terrifying. So the absolute rule is never treat a megaloblastic anemia with folate until you have definitively ruled out B12 deficiency.
Correct. Or you treat with both until you have the lab results back. You cannot risk masking the B12 deficiency and allowing the neurological damage to progress.
And we should quickly define pernicious anemia because it's the specific cause of B12 deficiency.
Yes, it's important not to confuse them. Most B12 deficiency worldwide is dietary, especially in vegans who don't supplement. But pernicious anemia is an autoimmune disease.
The body attacks itself.
Specifically, it attacks the parietal cells in the stomach. These cells produce a protein called intrinsic factor, which is absolutely essential for absorbing B12 from the gut. Without intrinsic factor, you could eat a whole cow and you wouldn't absorb any of its B12.
So the treatment has to be B12 injections to bypass the gut entirely.
Correct.
Okay, one last production failure before we move on. The most severe one, aplastic anemia.
A factory shutdown. This is the bleakest of the production disorders. The term aplastic just means failure to grow.
And it's not just the red cells. It's everything.
Everything. It's a pancytopenia, low red cells, low white cells, low platelets. It's a failure of the hematopoietic stem cell itself, the mother cell that gives rise to all other blood cells.
What causes that?
In many cases, we don't know it's idiopathic. But the leading theory for most of those is that it's an autoimmune attack. The patient's own T cells mistakenly identify the stem cells as foreign and destroy them. Other causes can be drugs, toxins like benzene, or radiation.
The description of the bone marrow biopsy is just chilling. The dry tap.
It is. Normally, when you do a marrow aspirate, you pull back a syringe full of this thick red cellular liquid. With aplastic anemia, you often get nothing, a dry tap. And when you look at the biopsy core under the microscope, where you should see a bustling city of developing blood cells, you just see empty space. It's mostly been replaced by fat.
A ghost town.
A ghost town where a factory should be. It's a devastating diagnosis.
Okay, that's a heavy note to end on, but we have to pivot. Let's leave the silent factory behind. Now, the factory is working. In fact, it's in overdrive. The reticulocyte count is high, but the cells are still disappearing. This takes us to the hemolytic anemias.
The crisis of survival. The normal red cell lives for about 120 days. In hemolytic anemias, that lifespan is drastically shortened.
And as the cells are destroyed, the body tries to compensate.
Right. You get two classic signs of hemolysis. One is the high reticulocyte count as the marrow tries to replace the lost cells. The other is the accumulation of the breakdown products of hemoglobin, particularly bilirubin, which leads to jaundice.
The yellowing of the skin and eyes.
Exactly. And Robbins makes a very useful distinction between two different crime scenes for hemolysis: extravascular and intravascular.
Let's start with extravascular. What does that mean?
Extravascular means the red cells are being destroyed outside of the blood vessels. And 90% of the time, that means they're being destroyed in the spleen or the liver. Robbins really frames the spleen as the main culprit here.
The villainous spleen again.
It's the primary filter. It has this incredibly tortuous network of passages called the splenic cords. A healthy, flexible red cell can deform itself and squeeze through. But if a red cell is old, stiff, or abnormally shaped, it gets stuck.
And what's waiting for it when it gets stuck?
Macrophages. Big eater cells. They are the quality control inspectors of the spleen. If a cell gets trapped, the macrophages recognize it as defective and phagocytose it. They eat it. This leads to splenomegaly, an enlarged spleen, because it's so full of overworked macrophages.
So that's the relatively orderly destruction in the spleen. What about intravascular hemolysis?
That's much more chaotic. Intravascular means the red cells are literally bursting open while they're still in the circulation. This is much more damaging because it releases a flood of free hemoglobin directly into the plasma.
And free hemoglobin is not supposed to be there.
It's very toxic. It gets filtered by the kidneys, and you get hemoglobinuria, dark, tea-colored urine. It can cause acute kidney injury. So the location of the hemolysis has major clinical implications.
Okay, let's look at the specific diseases that cause this. We can group them by what's wrong with the cell. First up, defects in the cell membrane itself. Hereditary spherocytosis.
It sounds complex, but the idea is simple. It's a problem with the cell's skeleton.
Red cells have skeletons.
They do. An internal protein scaffolding made of proteins like spectrin and ankyrin. This scaffolding is what gives the red cell its biconcave disc shape and, crucially, its flexibility. In hereditary spherocytosis, there's a genetic mutation in one of these proteins.
So the skeleton is weak.
The skeleton is weak. The membrane isn't tethered properly. As the cell tumbles through the circulation, little bits of its membrane bleb off and are lost. The cell is trying to contain the same amount of hemoglobin with less and less surface area.
And the shape with the lowest surface area for a given volume is a sphere.
Exactly. The cell rounds up, it becomes a spherocyte. The problem is spheres are not flexible. They are rigid.
And they can't squeeze through the splenic filter.
They hit the splenic cords and get stuck, trapped. And then they get eaten by the macrophages. It's a perfect example of extravascular hemolysis.
So the fundamental problem is the genetic defect, but the executioner is the spleen.
Precisely. Which is why the treatment can be a splenectomy. If you remove the spleen, you remove the trap. The cells are still defective spheres, but they can survive much longer in the circulation, and the anemia is cured.
A really elegant example of structure and function. Okay, next up, enzyme defects. The classic is G6PD deficiency. This one is linked to fava beans, right?
The famous favism, yes. But the core mechanism is about dealing with oxidative stress.
What is oxidative stress for a red cell?
Well, the red cell's entire job is to carry oxygen, a highly reactive molecule, so it's constantly at risk of being damaged by oxidation. It protects itself with an antioxidant system, and a key part of that system is an enzyme called G6PD.
Glucose-6-phosphate dehydrogenase.
Right. It helps regenerate another molecule called glutathione, which is the cell's primary defense against oxidative damage. If you are deficient in G6PD, your antioxidant shield is weak.
But you're okay most of the time.
Most of the time, you're fine. The problem comes when you're exposed to a major oxidative stressor. This could be a severe infection, certain drugs, like some antibiotics or antimalarials, or famously, chemicals in fava beans.
And when that trigger hits, the weak shield fails. What happens inside the cell?
The hemoglobin itself gets oxidized. The damaged hemoglobin molecules clump together and precipitate, forming these little solid inclusions inside the red cell called Heinz bodies.
Heinz spot?
Yes. These Heinz bodies are like little rocks inside the cell. They damage the membrane. And then, as the cell passes through the spleen, the splenic macrophages see these clumps and try to remove them. They take a literal bite out of the cell's cytoplasm.
Leaving a bite cell.
A bite cell. You can see them on the peripheral smear. It's a red cell with a chunk missing. These damaged cells are then rapidly cleared, leading to an episode of hemolysis.
Okay, so from membranes and enzymes, we move to the hemoglobin molecule itself. the hemoglobinopathies. Let's start with sickle cell disease.
A truly devastating disease, but a fascinating one from a molecular standpoint. It's all caused by a single point mutation in the gene for the beta-globin chain, a single letter change in the DNA code.
Which swaps one amino acid for another?
Glutamic acid gets replaced by valine, and this one tiny change completely alters the physical properties of the hemoglobin molecule.
How so?
When this abnormal hemoglobin, HbS, gives up its oxygen, when it becomes deoxygenated, it undergoes a physical transformation. The molecules link together, polymerizing into long, rigid, insoluble rods.
And these rods distort the entire cell.
They push on the cell membrane from the inside, forcing the normally flexible disc into a rigid crescent or sickle shape.
And Robbins highlights two catastrophic consequences of this sickling.
Yes. The first is a chronic hemolytic anemia. The sickling process damages the cell membrane, making it leaky and fragile, so the cells have a very short lifespan. But the second consequence is often more severe.
Vasoocclusion.
The traffic jam. These rigid, sticky, sickle-shaped cells can't navigate the narrow capillaries. They get stuck. They logjam the microvasculature, blocking blood flow.
And that leads to ischemia and infarction.
Tissue death. Exactly. This is what causes the excruciatingly painful pain crises when it happens in the bones. It's what causes acute chest syndrome in the lungs, strokes in the brain. And over time, it leads to cumulative organ damage.
And you mentioned a very specific outcome in the spleen, autosplenectomy.
It's one of the great ironies of hematology. In most hemolytic anemias, the spleen gets bigger. In sickle cell disease, the repeated sickling and vasoocclusion within the spleen's own blood supply causes it to infarct over and over again.
It destroys itself from the inside out.
By adulthood, the spleen is usually shrunken down to a tiny fibrotic, non-functional nub. The patient has effectively performed a splenectomy on themselves.
Wow. Okay, let's contrast sickle cell with the other major hemoglobinopathy, thalassemia. If sickle cell is a problem of hemoglobin quality, thalassemia is a problem of quantity.
That's the perfect way to frame it. Normal adult hemoglobin has 2 alpha-globin chains and 2 beta-globin chains. They are produced in a perfectly balanced 1-to-1 ratio. In thalassemia, there's a genetic defect that reduces or eliminates the production of one of those chains.
So you have imbalance.
A profound imbalance. Let's take beta thalassemia, where you can't make enough beta chains. You still make a normal amount of alpha chains, but they don't have a partner to bind to.
What do those unpaired alpha chains do?
They are incredibly toxic. They are unstable, and they precipitate within the red cell precursors while they are still developing in the bone marrow.
So they damage the cell before it's even born.
Yes. This leads to massive, ineffective erythropoiesis. The marrow is churning, trying to make cells, but most of them are so damaged by these precipitated alpha chains that they undergo apoptosis-programmed cell death right there in the marrow.
But the body just knows it's anemic, so it keeps screaming at the marrow to work harder.
The EPO levels are through the roof.
Right.
The marrow responds by expanding dramatically. It erodes the inner surface of the bones and can even expand out into soft tissues.
Which leads to that classic crew cut appearance on a skull x-ray.
Right. You see the bone spicules sticking out as the marrow erupts from the skull. It's a picture of the body's desperate but futile attempt to compensate.
And Robbins highlights another major danger in thalassemia: iron overload.
This is critical. These patients become overloaded with iron for 2 reasons. One is from repeated blood transfusions. But even without transfusions, they absorb too much iron from their diet.
Why is that?
Because the massive, ineffective erythropoiesis sends out signals that suppress hepcidin. The body thinks it needs more iron for all these new red cells it's trying to make. So it opens the floodgates in the gut, leading to iron deposition in the heart and liver, which is often the ultimate cause of death.
It's a cascade of devastating consequences. Okay, last category of hemolysis before we move to clotting. Immunohemolytic anemias.
The body turning on its own red cells. Here, the simple way to divide them is by temperature, warm versus cold.
Warm autoimmune hemolytic anemia involves Ig antibodies, right?
Yes. These are IgG antibodies that bind optimally to red cell antigens at normal body temperature, 37 degrees Celsius. They coat the red cell, a process called opsonization.
And the spleen recognizes these antibody-coated cells.
The macrophages in the spleen have receptors for the FSE portion of the IgG antibody. They see the coated cell as a target, but they often can't swallow the whole cell, so they just take a nibble of the membrane.
Which causes the cell to round up.
And become a spherocyte. Just like in hereditary spherocytosis, but for an acquired immune reason. This is often associated with other autoimmune diseases like lupus or can be triggered by drugs.
And cold agglutinin disease.
That's usually caused by IgM antibodies. IgM is a big pentameric molecule. It binds to red cells best at colder temperatures below 37 degrees. So in the cooler parts of the body, the fingers, toes, earlobes, these IgM antibodies cause the red cells to clump together or agglutinate.
And that can block small vessels.
It can, and it can also activate the complement cascade, which can lead to intravascular hemolysis when the cells warm up again. This is classically associated with infections like mycoplasma pneumonia or mononucleosis.
So warm equals IgG, spleen and nibbling. Cold equals IgM, extremities and clumping.
A very good summary.
We've spent a lot of time on the failure of the delivery system. Now we have to shift our focus to the containment system. Section 4, haemostasis and its disorders.
The balance of clotting. I find it helpful to think about this as a two-stage construction project. You have bricks and you have mortar.
Bricks and mortar. I like that. What are the bricks?
The bricks are the platelets. This is primary haemostasis. When you get a small cut, the first thing that happens is that platelets rush to the scene and form an initial temporary plug.
And what's the mortar?
The mortar is the fibrin mesh. That's secondary haemostasis. This is the end product of the coagulation cascade, and it's the strong, stable glue that reinforces the platelet plug and turns it into a durable clot. You need both to properly fix a hole in the wall.
So let's talk about the bricks first. Primary haemostasis. What kicks it off?
Injury to the blood vessel wall exposes stuff that's normally hidden from the blood, mainly collagen and a crucial protein called von Willebrand factor, or VWF.
And VWF is like the primer on the wall.
It's like molecular Velcro. Platelets have a receptor that sticks to VWF. This adhesion causes the platelets to activate. They change shape, release chemicals, and express another set of receptors that lets them stick to each other. They aggregate.
Adhesion, activation, aggregation. And that forms the initial plug.
That's the brick wall.
So what happens if this system fails? What does the bleeding look like if you have a platelet problem?
This is a really key clinical distinction. Platelet-type bleeding is characteristically superficial and mucosal. Think nosebleeds, bleeding gums, heavy menstrual periods. And on the skin, you see petechiae.
Those tiny pinpoint red dots.
Right. It's because the thousands of tiny micro-injuries that happen in our capillaries every day aren't being sealed. The plumbing has thousands of microscopic leaks.
And what can go wrong with platelets?
Two main things. You can have not enough of them. Thrombocytopenia. A classic cause is ITP, immune thrombocytopenic purpura, where the body makes antibodies that destroy its own platelets. Or you can have a normal number of platelets, but they don't work right.
Functional defects.
Like Bernard-Soulier syndrome, where the platelets are missing the receptor to stick to VWF, they can't adhere. Or Glanzmann thrombocythemia, where they're missing the receptor to stick to each other, they can't aggregate.
Okay, so that's the bricks. But for a major injury, a loose pile of bricks isn't enough. You need the mortar. Secondary haemostasis.
The coagulation cascade. This is that complex diagram of Roman numerals you see in textbooks. It's a series of enzymes or factors that activate each other in a domino effect.
And the final domino is?
Thrombin. Thrombin is the mastol enzyme. It takes a soluble protein in the blood called fibrinogen and clips it, turning it into insoluble fibrin strands. Those strands are the mortar. They polymerize into a mesh that cross-links the platelet plug and makes it strong.
And if this mortar-making system fails, think of hemophilia.
The bleeding pattern is completely different. Because primary hemostasis is intact, you don't get petechiae. The initial platelet plug forms, so a small cut might stop bleeding for a minute.
But the fix is temporary.
Very temporary. Without the fibrin mortar to stabilize it, the plug is weak and friable. It quickly washes away and the bleeding restarts. This leads to a pattern of delayed, deep tissue bleeding.
Like bleeding into joints. Hemarthrosis.
Exactly. The classic finding in severe hemophilia. Just from normal activity, you create microtrauma in your joints. In a healthy person, this is sealed instantly. In a hemophiliac, it causes a slow bleed into the joint space, which is incredibly painful, and over time destroys the joint.
So hemophilia A is a lack of factor VIII, and B is factor IX. Where does von Willebrand disease fit into this picture? This seems to be a mix of both.
It's the perfect bridge between the two systems, because VWF has two jobs. We already said job one is being the Velcro for platelets. That's primary hemostasis.
And job two.
Job two is to act as a chaperone for factor VIII in the blood. It binds to factor VIII and protects it from being cleared from the circulation too quickly.
So if you don't have VWF,
you have a double whammy. Your platelets can't adhere properly, so you get platelet-type bleeding like nosebleeds. And your factor VIII levels will be low because it doesn't have its protector, so you can also get features of mild hemophilia. It's the most common inherited bleeding disorder, and it presents on a wide spectrum.
Okay. We've talked about what happens when you don't have enough bricks or mortar. Now we come to the final terrifying paradox.
Yeah.
The system loses all control. Section 5, disseminated intravascular coagulation, or DIC.
The ultimate hemostatic catastrophe. Some people joke it stands for death is coming.
That's grim. But it speaks to the mortality rate. You describe it as a paradox. What's the paradox of DIC?
The patient is bleeding uncontrollably because they are clotting uncontrollably.
How is that possible at the same time?
It starts with some massive systemic insult to the body. Sepsis is the classic trigger, but also major trauma, obstetric complications, or some cancers. This insult leads to the widespread systemic activation of the coagulation cascade.
So instead of making a clot at one site of injury, you start making clots everywhere.
Everywhere. Thousands and thousands of tiny fibrin clots, microthrombi, form in the small vessels throughout the body, in the kidneys, the lungs, the brain. This blocks blood flow and causes widespread ischemic organ damage.
Okay, so that's the clotting part. Where does the bleeding come from?
It's a supply and demand problem. You are using up all of your platelets and all of your coagulation factors to make these millions of tiny clots. It's called a consumptive coagulopathy.
You run out of building materials?
The cupboard is completely bare. So now the patient has no ability to form a clot where they actually need one at an IV site, in the GI tract, in a surgical wound. They ooze and bleed from every puncture site because they've used up all their bricks and mortar elsewhere.
And it gets worse, doesn't it?
Yeah.
The body tries to fix it.
It does. The body's clot-busting system, fibrinolysis, goes into overdrive trying to dissolve all these microthrombi. This creates a large amount of fibrin degradation products, or FDPs.
And what do?
The FDPs themselves act as anticoagulants. They interfere with platelet function and fibrin polymerization. So the body's attempt to fix the clotting problem actually makes the bleeding problem even worse. It's a complete vicious downward spiral.
And this brings us all the way back to the red blood cells, because DIC causes a very specific kind of hemolytic anemia.
It does. It's called microangiopathic hemolytic anemia, or MAHA.
Explain that.
As red blood cells try to squeeze through these capillaries that are now crisscrossed with strands of fibrin from all the microthrombi, they are physically sheared apart.
So the fibrin mesh acts like razor wire.
Exactly. It slices the red cells into fragments. When you look at the blood smear, you see these bizarrely shaped, fragmented red cells. Some look like helmets. They're called schistocytes.
So DIC is the ultimate systems failure. It ties everything together. The clotting system goes haywire, which consumes the clotting factors leading to bleeding, and also destroys the red cells, leading to anemia and organ failure.
It is the complete loss of regulation. It's not a primary disease. It's a catastrophic complication of something else, but it shows just how deadly it is when the balance of homeostasis is lost.
We have covered an incredible amount of territory, from the raw materials in the bone marrow to the physical properties of the cell membrane, all the way to this cascading disaster of DIC.
And if you take a step back, the big theme that emerges from both Robbins and Underwood's is that pathology is so often just normal physiology gone wrong. It's an exaggeration or a failure of a normal process.
The spleen in spherocytosis isn't being malicious. It's just doing its filtration job too well on defective cells.
Exactly. And the coagulation system in DIC isn't some alien process. It's the normal clotting mechanism, just activated systemically and without any of its normal checks and balances.
And I think for you, listening to this, the goal is to be able to connect these mechanisms to what you see in the clinic or on a lab report. When you see spoon nails, your brain should immediately think iron, hepcidin, potential GI bleed.
When you hear about a child with painful swollen joints, you think deep tissue bleeding, secondary haemostasis, coagulation factors. When you see schistocytes on a smear, you think MAHA, physical shearing, DIC. The story is written in the blood.
Before we sign off, I want to leave everyone with one final thought, something to chew on. We've talked about sickle cell and thalassemia as these horrific genetic diseases. So the question is, why do they still exist at such high frequencies in certain populations? Why haven't they been eliminated by natural selection?
That is one of the most classic and compelling stories in all of medicine, and Robbins touches on it. The answer is an evolutionary trade-off. The answer is malaria.
How does malaria fit in?
The malaria parasite, Plasmodium falciparum, spends a critical part of its life cycle replicating inside human red blood cells. It turns out that having one copy of the sickle cell gene, the sickle cell trait, or being a carrier for thalassemia makes the red cell a very inhospitable home for the parasite.
So the parasite can't grow as well.
It can't grow as well, and the defective red cells are often cleared more quickly by the spleen, taking the parasite with them. So, in regions of the world where malaria has been historically endemic, like parts of Africa and the Mediterranean, carrying one of these mutations conferred a significant survival advantage. You are less likely to die from malaria.
So a gene that is deadly when you have two copies of it is protective when you only have one.
It's a textbook example of balancing selection. It's a stark reminder that the body is a series of compromises shaped by immense environmental pressures over millennia.
A gene that saves you from a parasite in one context can destroy your organs in another. Nature is truly relentless.
It is indeed.
Well, that's all the time we have for this deep dive. As always, remember that this conversation is the map, not the territory. You absolutely need to go back and read the source material.
Please read the chapters, the details on the specific mutations, the enzyme pathways. That's where the deep learning happens. We've just given you the framework to hang it on.
Thanks for listening. We will catch you on the next deep dive.